Welcome to the third lecture in a series of lectures on pediatric cardiac anesthesia. In this lecture, Dr. Ching-Kit Chen, from Pediatric Cardiology, explains various imaging studies for preoperative assessment in the setting of congenital heart disease. These include echocardiography, cardiac MRI, cardiac CT, and cardiac catheterization.
As a whole, we can divide the cardiac assessments into two main categories. Number one, non-invasive cardiac imaging. Of course, secondly, we can have invasive cardiac imaging using cardiac catheterization to perform angiogram or hemodynamic measurement, as well as to perform intervention. From the perspective of non-invasive cardiac imaging, the commoner investigation by far is still echocardiography, be it transthoracic or transesophageal. In adult, transesophageal echo is performed quite commonly, but in children it is quite difficult to perform transesophageal echo because, number one, they need sedation. Usually we do it under anesthesia because the tone of the pharyngeal muscles are so high that it is really quite difficult to insert the transesophageal probe. Now, this is also applicable to the younger adults. So in the young adult settings where we perform TEE, we oftentimes have to give them some form of sedation. The older people tend to have a lower muscular tone in the pharyngeal region, and therefore the TE probe tends to be easier to be inserted. Other forms of non-invasive cardiac imaging that have taken traction in the recent decade include cardiac MRI as well as cardiac CT. And I will go through the individual modalities, what are the advantages and what are the disadvantages of each investigation modality in order for you to get a sense of how we decide which test to perform. And of course, I'm not going to go into the theoretical aspect of things. I'm going to approach it from a more practical aspect by showing you some of this congenital heart disease that are commonly repaired in our setting. Let's look at echo. Echo is an ultrasound-based imaging, and of course we know that it is excellent in providing us an anatomic, functional, as well as hemodynamic assessment. It gives us very good temporal resolution to the cardiac imaging. It is widely available, easily obtained in the cardiac clinic, even portable machine is available. It is low cost in the grand scheme of things when you compare it with cardiac CT, cardiac MRI, or even cardiac catheterization. It's safe, hardly needing any sedation. Most of the patients do not need sedation except those below 3 years when they are uncooperative, and therefore we give sedation, and even then we give oral chlorohydrate sedation, which is a very mild sedative. We do not need radiation for echo. It is portable, as I mentioned earlier on, and it can even be performed in those who are hemodynamically unstable in the ICU setting. However, there are a couple of limitations. Number one, we all know any ultrasound-based imaging is highly operator dependent. It depends on whether or not the sonographer or the echocardiographer is experienced enough to know what to look for and how to look for it. So this is something that is one of the greatest limitations of echocardiography. Beyond which, echo, although it provides excellent temporal resolution, the spatial resolution, however, is not quite as good because we are limited by the sector width of the ultrasound and of course by the acoustic window that it provides. So it doesn't give us very good extracardiac abnormality characterization, especially when it is in intraparenchymal in the lungs. Then the air prevents the ultrasound wave from traveling into the area, and therefore we would not be able to see any structure that is intraparenchymal. Of course, if the patient is on a more obese side, if the lung pathology causes the hyperinflation of the lungs, as well as a child's chest deformity, it could limit our acoustic window quite significantly, in which case then we have no choice but to proceed on to other forms of cardiac imaging in order to obtain the anatomy or the functional assessment. The next most common cardiac imaging that we perform from the congenital heart disease perspective is cardiac MRI. It gives us the same anatomic and functional assessment, but with much higher spatial resolution. It is highly reproducible. It's not quite as dependent as operator as ultrasound-based imaging. It allows volume quantification, especially the right ventricle, and I will show you an example of this shortly at the end of the during one of the examples of the patients. Although echo can be used to measure or estimate volume, right ventricular volume measurement is quite challenging when it comes to ultrasound. It allows us to evaluate extracardiac associated vascular abnormalities where areas where echo cannot reach. It is very expensive, however. It's like at least $1,000 for a cardiac MRI as compared to we're talking about $350 in NUH for a transthoracic echo for a private rate. It has a long acquisition time. A cardiac MRI may need at least up to 1 hour for us to complete the assessment, and depending on what type of other extra imaging that may be needed, echo may take anything between 30 to 45 minutes for a full cardiac anatomy as well as a functional assessment. Some patients can get quite claustrophobic. It is not suitable for those who are hemodynamically unstable, and we may need to use contrast, especially if you want to look at anatomy of the vasculature. And of course, it is contraindicated in those with metallic implants. For children, those who are uncooperative and those who may not be able to hold still, sedation or even general anesthesia would be required, whereas as I mentioned earlier on, echo we rarely need to perform under general anesthesia, almost never. Moving on to cardiac CT, which is also fairly common after cardiac MRI. The advantage, it has an excellent spatial resolution, even better than cardiac MRI because vessels are better seen when it comes to cardiac CT, especially the smaller vessels, like for example the coronary arteries. It has limited functional assessment. We can do functional assessment on cardiac CT, but MRI is still by far the gold standard when it comes to cardiac functional assessment. Evaluation of extracardiac associated abnormalities is best done with cardiac CT, especially when the lung windows come into play. We can look at the intraparenchymal vasculature in terms of pulmonary artery assessment. We can detect and quantify vascular calcification, whereas we cannot do this on MRI. We can't do this on echo. So you hear about coronary calcium scoring in those with ischemic heart disease. So cardiac CT is very good at performing this aspect of the assessment. Beyond that, we can also assess pericardial calcification. Now, we can't do that for echo, although we can tell you that the pericardium may appear echogenic, but a lot of pericardiums may appear echogenic on ultrasound. But we can't be certain, and we can't detect or quantify that for certain using ultrasound, and cardiac CT gives us the best resolution and information. One of the greatest limitations of cardiac CT is the radiation, and the dose of radiation is directly dependent on the form of assessment that we want. If we want functional assessment, meaning flow, ejection fraction, contractility, then the dose of X-ray will be significantly higher, as we need to acquire the images throughout the entire cardiac cycle. However, if we're just doing a limited assessment, meaning just anatomic, we can just pick one certain part of the cardiac cycle and do the radiation at that point in time, rather than exposing the patient to a high radiation dose. Of course, we need contrast, much like in MRI, whereas in echo, we do not need contrast. You may have heard that we use agitated saline contrast in certain indications, but this is far and few between. Functional evaluation require higher radiation dose, as I mentioned earlier on. If I want to capture it during systole, I want to capture it during diastole, then the entire cardiac cycle has to be captured, and we have to irradiate the patient throughout the entire cardiac cycle. It is not suitable for those who are hemodynamically unstable, unlike echo. Of course, we all know that there is a portable cardiac CT, but that significantly limits the resolution that we may have from the imaging. Moving on to an invasive form of cardiac imaging, cardiac catheterization. One of the advantages, we can use it for diagnostic purposes. From the diagnostic perspective, we can stick in catheters to measure directly the hemodynamics, meaning we can evaluate the pressures within each chambers in the great vessels directly, and it's accurate. We can also do angiogram to delineate the anatomy of especially the vessels, to look for stenosis, dilatation, aneurysm. Beyond just diagnostic purposes, whilst doing cardiac catheterization, it allows us to intervene should an intervention be deemed necessary prior to the planning of the imaging. Of course, it is invasive. This is one of the most limiting factors when it comes to the application of cardiac catheterization. It is also involves radiation, although the dose of radiation may be quite low. We usually would document the duration of our fluoroscopy, and we try to reduce or minimize the dose of radiation that we use. It involves contrast, without which we will not be able to delineate the anatomy beyond just obtaining the hemodynamics. And of course, in children, it requires anesthesia. Oftentimes, I have not performed cardiac catheterization under sedation, although in adults you do it under sedation. We have not performed it under just moderate sedation. Most of the time, if not all the time, we do it under general anesthesia. The other thing is that the spatial resolution as well as the temporal resolution may not be very good, because it's like doing X-ray. The AP plane as well as the lateral plane is not quite like CT or MRI, where we can do axial imaging simultaneously. So we're just doing biplane two-dimensional imaging during cardiac catheterization, and therefore the temporal and the spatial resolution would be significantly limited. Now, having brought you through some of these advantages and disadvantages of the various forms of imaging, I'm going to show you some of the examples of the congenital heart disease for whom we present to the surgeon for consideration of surgery. Now, when it comes to the commonest congenital heart disease in children, it is ventricular septal defect, and this is the commonest cardiac surgery that we perform in surgery, closure of the ventricular septal defect. In ventricular septal defect assessment, echo is amply sufficient. As you can see in a long axis view, we have the RV anteriorly and the LV posteriorly, and with the ventricular septum right horizontally in the echo imaging plane. And on color, we could see flow across the ventricular septum. And we can see that it is red in color, meaning it's shunting from the LV towards the right ventricle. So we can delineate the anatomy here to show the surgeon the location of this VSD. Qualitatively, we could also look at the ventricular function, and of course we could objectively quantify the function of the ventricle, the function of the right ventricle prior to surgery. We could also do hemodynamic estimation using echo. When we say hemodynamic assessment estimation, what are we looking at? We're interested in the pulmonary pressure, and therefore using Doppler principle, by using pulse wave or continuous wave, we could actually estimate the pressure difference between the left ventricle and the right ventricle. As such, if you can see this Doppler tracing, we could see that the velocity of this jet across this ventricular septal defect is 3.17 meter per second, and using the modified simplified Bernoulli equation, we derive that the pressure gradient across the ventricular septal defect is estimated to be 40 mmHg. How do we then estimate the hemodynamics here? We use it to estimate the right ventricular pressure as a surrogate of the pulmonary arterial systolic pressure. If I can get the cuff blood pressure for this patient, and in this case, the systolic blood pressure in this patient was 72 mmHg. And if I minus 40 from this 72, I get 32. So the estimated right ventricular systolic pressure is 32, and therefore, in the absence of right ventricular outflow tract, I have a pulmonary arterial systolic pressure of 32 mmHg. And how do we make sense of this number 32? So we compare it with the left ventricular systolic pressure. So 32 out of 72 is slightly less than half systemic, but more than 1/3 of the systemic blood pressure. So this is mildly elevated pulmonary pressure in assessing of the ventricular septal defect. So this VSD is significant, with hemodynamic significance contributing to pulmonary overcirculation and mild elevation of the pulmonary blood pressure. I'm going to pause here for a while. Does this make sense? And please feel free to jump in and ask me any questions if you have any. And if I'm going too quickly, do let me know. The next thing that we commonly see in terms of ventricular shunting, or in terms of congenital heart disease, which is not that common when you compare it with ventricular septal defect, is atrial ventricular septal defect. Now, as I mentioned earlier on, in the setting of ventricular septal defect, echocardiography in itself would be sufficient. We will never, hardly ever do we need to move on to doing a cardiac MRI or cardiac CT, let alone cardiac catheterization, unless there are information that we cannot obtain. For example, there's any extra cardiac pathologies, example problems in the lungs that we would like to delineate before going in for surgery. Beyond which, if it is just an isolated ventricular septal defect, echo would be more than sufficient without having to move on to other forms of imaging. Now, when it comes to atrioventricular septal defect, this is a complete atrioventricular septal defect. We can see on the four-chamber view the left ventricle and the right ventricle, and the center of the heart is completely missing. So there is a deficiency in the ventricular septum in the inlet region, and in the atrial septum there is also a deficiency in the atrial septum and the ostium primum region. So it's a complete AVSD. And in the setting of a complete AVSD, beyond just patching up the atrial septum, patching up the ventricular septum, the surgeon also needs to have a look and evaluate the atrioventricular valve, which is abnormal, because they need to decide if they need to fix this atrioventricular valve. Now, what do I mean? In AVSD, it is not just the deficiency or the defect in the atrial septum or in the ventricular septum. The atrioventricular valves are also abnormal. Now, in this diagrammatic depiction of a normal mitral valve and a normal tricuspid valve, you can see the mitral valve has two leaflets like a fish mouth, and tricuspid valve has three leaflets, as the name implies, located on the right side. In atrioventricular septal defect, beyond just the septal defect, the atrioventricular valves are abnormal. So we have a common atrioventricular junction here rather than two separate atrioventricular junctions. We have the pathognomonic feature of AVSD is a common atrioventricular junction, and also abnormality in the AV valve, where instead of having two separate AV valves, we have one common AV valve with 5 leaflets. We can have one common AV valve orifice, or we can have two separate AV valve orifices if there is a bridging or a tongue of tissue that bridge the anterior bridging leaflet from and the inferior bridging leaflet. In the setting of a complete AVSD, we are able to then use echo, three-dimensional echo, to evaluate the AV valve itself to show the surgeon how abnormal these AV valves look. Do they need to fix it intraoperatively? As you can see, if I orient you, this is the aorta anteriorly, and that's the left AV valve, this is the right AV valve. And if I can get it to play, you can see that this is an abnormal AV valve with the anterior bridging leaflet anteriorly, and of course with the posterior bridging leaflet posteriorly, and contributing to the common AV valve. And this is something that we can do on echo. We can give the spatial resolution. Here we can see the 5 leaflets. We can also give the temporal resolution. This dynamic is opening and it's closing during each cardiac cycle. When a surgeon goes in and institute cardiac pulmonary bypass, the heart is static, and the surgeon would not be able to appreciate the dynamic aspect of this valvular pathology during the operative period. And cardiac CT and cardiac MRI would not be able to give this kind of resolution without the radiation and without the long acquisition time. On the other hand, the simpler, a less severe form of AVSD is that of an intermediate atrioventricular septal defect. Now, a case in point is that this is an 8-year-old boy who was incidentally detected to have cardiac murmur, and we do not appreciate any septal defect here, but the murmur was due to what was thought to be a mitral regurgitation. You can see this mitral regurgitant jet on the left side here. And initially it was thought to be a moderate mitral valve regurgitation due to a cleft in the mitral valve. But as we apply three-dimensional echo imaging on it, we could see that this is not just a cleft of the mitral valve. You could see that the left AV valve here doesn't have the mitral configuration as we would expect, the two leaflets. There are three leaflets here, and the leaflets extend all the way to the crest of the ventricular septum, very reminiscent of that of a complete of an atrioventricular septal defect, in which there is common atrioventricular junction, and this is part of the anterior bridging leaflet, this is part of the inferior bridging leaflet. Now, this kind of imaging will not need cardiac MRI or cardiac CT for us to go ahead and plan for the surgery. Moving beyond the left to right shunts, we are going to talk about one of the commonest cyanotic congenital heart disease, the tetralogy of Fallot, that is characterized by four features. Number one, right ventricular outflow tract obstruction from the pulmonary stenosis. The coronal septum here is prominent and deviated towards the right ventricular outflow tract, and therefore obstructing the pulmonary outflow tract and resulting in pulmonary stenosis. The second thing is, of course, the ventricular septal defect, as the coronal septum deviates towards anterior superiorly, is dragging the aortic valve anterior superiorly, causing overriding aorta, which is then the third feature. And the chronic right ventricular outflow tract obstruction results in right ventricular hypertrophy. On 2D echo, we could see that the coronal septum here is prominent, and together with the prominence of the septal-parietal trabeculation result in right ventricular outflow tract obstruction. We could also see the perimembranous location of this large ventricular septal defect. Beyond just looking at the characteristic of the tetralogy of Fallot, one of the other associated abnormalities that need to be determined is the coronary arteries. In 10% of children with tetralogy of Fallot, there is coronary artery abnormalities in which the left anterior descending artery comes off the right coronary artery. In this case, this echo shows that the left coronary artery arises normally from the left coronary cusp, and it branches into the left anterior as well as the left circumflex arteries normally. And we can use color to show the flow, and you can see the flow obstruction in the right ventricular outflow tract depicted by this pulmonary stenosis and the flow across the ventricular septal defect. We could also use echo then to demonstrate the flow across the left coronary artery, and in this case we really didn't quite need a cardiac CT to show us the coronary artery. You could see this left coronary artery that's forming the left anterior descending normally. We can also use this beyond just to determine the anatomy, the function. We could also use this to assess the hemodynamics, how severe is right ventricular outflow tract obstruction is, and in this case with an estimated right ventricular outflow tract pressure gradient of 53 mmHg. But just take note that the echo tends to overestimate pressure gradient by a little bit for various reasons that are specific to ultrasound imaging and Doppler interrogation. And we could also look at the valve. 25% of the tetralogy of Fallot have bicuspid pulmonary valve, and this is the pulmonary valve that is a little bit more anterior compared to the aortic valve, and it looks like it's a fish mouth that is opening and closing. And this is important for the surgeon to decide, do they need to sacrifice this pulmonary valve and therefore perform transannular patch and causing pulmonary regurgitation? I'm going to explain a little bit more to you later. A case in point of a coronary artery abnormality is this, that we have the right coronary artery coming off the anterior sinus of Valsalva, causing towards the right. But at the same time, you could also see another coronary artery that's branching off this right coronary artery that is directed towards the left. And on color, you could see that this is the normal origin of the right coronary artery, and indeed on color you can see color flow in this vessel that is coursing towards the left side across the right ventricular outflow tract. And now this is not normal. RCA, the right coronary artery, usually comes off the right, the anterior sinus of the valsalva, and just purely goes on to the right to supply the right ventricle. And this dominant branching here is suggestive of a left anterior descending artery that is crossing the right ventricular outflow tract. Now, this is highly important for the surgeon to know, because if the surgeon is not aware of this preoperatively, and if they are going to do a ventriculotomy to open up the right ventricular outflow tract, they may inadvertently transect the left anterior descending artery, and thus compromising the coronary blood flow to the left ventricle. And this has happened before if the surgeon is unaware of this and have not taken note to look at the left anterior descending artery. In situations like this, although the echo can show the coronary artery fairly well, we may then need to proceed on to do a CT of the coronary artery, in which case I'm going to show you this CT angiogram for this particular patient, for whom we have then subjected to coronary CT in order to evaluate it for sure. You can see the right coronary artery coming off the anterior sinus of valsalva here, directed towards the right. And we can also see that there is another artery, coronary artery, that's causing towards the left, towards the right ventricular outflow tract, confirming the suspicion on echo. However, if you can tell, I'm sure you have seen clearer cardiac CT or clearer CT coronary angiograms. Now, this is one of the things in children where the child is not fully sedated, not fully cooperative, or higher respiratory rate compared to adults, then motion artifact can be introduced, limiting the definitive resolution of the coronary artery imaging. So the radiologist has surmised that the coronary CT did not add further value to the echo that has been done for this patient. So that's one of the applications of using cardiac CT and in addition to echocardiogram in the setting of the trilogy of failure to look at coronary arteries. Of course, there are other congenital heart disease with coronary artery abnormalities that may benefit from coronary CT. And of course, if the sonographer or the cardiologist is not able to evaluate other structures, for example, what is important is the branch coronary arteries, clearly either because of the limitation in the skills or limitation in the acoustic window, then we will have to then proceed on to do a cardiac CT to evaluate the branch pulmonary arteries, which is highly pertinent for the cardiac surgeon to know prior to surgery itself, to decide if they need to do an augmentation of the branch pulmonary arteries. And you can see that in this situation, the right pulmonary artery and the left pulmonary arteries are diffusely hypoplastic in a child with the trilogy of Fallot. We will also then do additional cardiac imaging beyond just echocardiogram in a post-op setting. For example, a patient with the trilogy of Fallot who had undergone full repair and required transannular patch. And this is what a transannular patch looks like. If the pulmonary valve annulus is of inadequate size, the surgeon would have no choice but to do a transannular patch to open up the right ventricular outflow tract using a patch. Because if we do not do that and we just resect muscles and close out the VSD, the right ventricle will still face a right ventricular outflow tract obstruction owing to the small pulmonary annulus. And that will contribute to acute right ventricular failure if the surgeon do not do a transannular patch. But by doing a transannular patch or transannuloplasty, we are sacrificing the pulmonary valve and causing severe or massive pulmonary regurgitation. And in the short term, in the initial 10 to 15 years of life, the RV tends to be able to cope with its pulmonary regurgitation because it's low pressure, the RV is hypertrophied to begin with, and the right side tends to take on volume overload better than the left side. We tend to leave it for a long period of time. Now, this is an example of pulmonary regurgitation where the transannular patch was performed. You can see that the right ventricular outflow tract has been opened up, but yet there is this jet of pulmonary regurgitation that is coming back into the right ventricle. Chronically speaking, that by the time the child hits 15-20 years of age, the RV would have been significantly volume overloaded and therefore warranting us to do a pulmonary valve replacement before the patient goes into heart failure from chronic overload of the right ventricle, subjecting the RV and the LV to fibrosis in the long term. And therefore, we need to decide when do we pull the trigger to subject the patient to a pulmonary valve replacement. Why is it difficult for us to decide? Because each pulmonary valve that we replace doesn't last forever. There is the durability of the pulmonary valve that we have to consider. On average, a homograph pulmonary valve lasts approximately 8 to 10 years. It means that at every 8 to 10 years, the child needs to undergo a replacement of this pulmonary valve. It's just quite a lot in the entire lifetime of a patient living with congenital heart disease. And therefore, we need to use other forms of imaging to decide what is the right ventricular volume, at which point we will pull the trigger and replace the pulmonary valve. As I mentioned earlier on, echo is very good at assessing left ventricular volume, and in this case with a patient with a dilated cardiomyopathy, we could use three-dimensional echo to do volumetric assessment to even assess the volume of the end-diastolic volume and systolic volume and the ejection fraction. This is because the LV has a nice bullet shape for us to do a quantification on echo. But the RV has a very odd shape, and we can't use echo to evaluate the volume, not quite as yet as a point of care. And therefore, we have to proceed on to doing a cardiac MRI. The cardiac MRI allows us to do volume quantification of the RV where echo cannot do so. And it is highly important for us to know what is the volume of the right ventricle, an accurate assessment of it in order to allow us to make a good decision rather than subjecting the child to premature surgery to replace the pulmonary valve. Now, I can't clip all these images onto the presentation slide because if I were to show you the cine movement, I don't seem to be able to save this into the PowerPoint slide. You could see MRI, one of the advantages of MRI is that there's no radiation, that you can assess function. You can look at it qualitatively and look at the contractility of the right ventricle and look at the contractility of the left ventricle. And we can also do quantification of volume in order to be able to obtain the ejection fraction of the left ventricle as well as the right ventricle. On this particular cine image, you can see that the right ventricle is very dilated in the setting of a child who had the tracheal repair with transannular patch with massive pulmonary regurgitation. You can see the RV is massively dilated and the function is just mildly impaired. And using quantification, the radiologist will be able to give us the right ventricular volume. Now, in the community, we usually would then take a cutoff of 170 ml per meter square of RV volume as a cutoff to send the child for surgery before the RV dilates further and causing heart failure. Now, the MRI is then also able to do something that echo is not so good at doing still. Let me just pull up the particular sequence here. Now, it's able to quantitate the regurgitant fraction of pulmonary regurgitation. If I were to show you this, the radiologist would then tell us how many percent of the blood that gets ejected out into the pulmonary artery gets regurgitant back into the RV and therefore compromising cardiac output. Now, we're not just saying that we're going to use imaging to make decision for important trigger point like deciding on pulmonary valve replacement. Beyond just cardiac MRI, we also look at symptoms. And if we're not sure whether or not the patient needs a pulmonary valve replacement, although the patient may have met the cutoff of volume, then we will do cardiopulmonary exercise testing to evaluate the functional status of this patient prior to sending the child for surgery. Other forms of imaging congenital heart disease includes partial anomalous pulmonary venous drainage. On echo, we can see that this is the SVC and this is the pulmonary anomalous right superior pulmonary vein that's coming into the SVC. Now, the problem with echo is that I need to tell you what you are looking at. It's not quite as intuitive. If I hadn't told you that this is the SVC, you probably wouldn't know what I'm trying to demonstrate here. But once I've explained this to you, the surgeon would know that, there is an anomalous pulmonary vein that's draining into the right-sided superior vena cava. But if I do a CT, anyone can look at it, and it's fairly intuitive, where we can say that this is the RA, this is the SVC, and we have an anomalous vein that is coming into the right superior, that's going into the right-sided superior, right-sided SVC. And in a sagittal cut, we can also see this huge orifice here of the right superior pulmonary vein draining into the SVC. The radiologists can also do 3D reconstruction to show us the pulmonary vein that's draining into the SVC. And at the same time, simultaneously looking at the other pulmonary veins, we have 2 on the left and only 1 on the right inferior pulmonary vein, whereas the right superior pulmonary vein drains into the right-sided superior vena cava. Now, this is the advantage of cardiac CT that echo cannot achieve. It is intuitive. Anyone can look at it, and surgeon can pick it up and look at it at any point in time without having someone to walk them through the imaging. But beyond that, MRI can also be used to do quantification. How significant is this left to right shunting? Now, using MRI, the radiologist is able to estimate or calculate the QP/QS. Q stands for flow. What's the ratio of flow to the lungs as compared to the systemic blood flow? Now, anything below 1.5 is considered negligible. In this case, this PAPVD has resulted in a pulmonary overcirculation with a ratio of 2.97. This is using MRI. But when we did that during echo, we had an estimated QP/QS of 3.1, which is not too far off using echocardiogram to assess the hemodynamic significance of a particular lesion. What I'm trying to say is that if we can do it on echo, echo is a good estimate, although cardiac MRI is still the gold standard, but because of its limitations, we do not always readily perform them. Moving on, if we need to do extracardiac imaging, then echo cannot do it. Echo cannot see airways. Echo will not be able to see anything that's within the intraparenchymal space. Using cardiac CT, we can see there's an indentation to the trachea here from the dilated aorta that's compressing onto the trachea. And you can also see, this is from looking from the back, that this is a right-sided bronchus. This is looking at it from the anteriorly. This looks like the right-sided bronchus, but which is on the left. And this looks like the left-sided bronchus, which is on the right. So this is a setting of a patient with thoracic situs inversus, or mirror image of the thoracic anatomy. Last but not least, we use cardiac catheterization to assess hemodynamics. Especially in this day and age, we rarely do cardiac catheterization for diagnostic purposes anymore, but only in this group of patients with consideration for Fontan circulation that we do cardiac catheterization for diagnostic purposes. The patient with single ventricle physiology would then undergo staged palliation, initially with the bidirectional cable pulmonary connection, or BCPC, also eponymously called the Glenn anastomosis, where the SVC is anastomosed to the right pulmonary artery. Prior to the completion of Fontan, either the lateral tunnel or the extracardiac Fontan, the current trend is to do extracardiac Fontan. We will need to do some hemodynamic assessment, because this is a passive blood flow. Blood is going to flow to the lungs without the energy that is going to be supplied by a ventricle. And therefore, we need to be sure that the hemodynamics status within the pulmonary vasculature is ideal for completion of the Fontan. And this can only be achieved using cardiac catheterization, and not even with cardiac CT or cardiac MRI. So cardiac CT can give us angiogram. We can do CT angiogram, and we can do angiogram on cardiac catheterization too. As you can see that the catheter is within the innominate vein directed towards the SVC, and as we play it, you can see the contrast flowing down the SVC into the branch pulmonary arteries. This can be easily done on cardiac CT without the invasive nature and without the general anesthesia that we subject the patient to. However, cardiac CT, this can also be done on echo. You can see the SVC connected to the branch pulmonary arteries, and on color flow you can also see, but not quite as high spatial resolution as that of the cardiac angiogram, but we can still see it on echocardiogram if the sonographer is well skilled at doing it. We can even see the mild narrowing or constriction of the branch pulmonary arteries here. But what both echo, cardiac CT, and cardiac MRI cannot give us is the hemodynamic assessment, where we are able to assess the various chamber pressures to determine the suitability for us to proceed with the completion of Fontan. Because if the pulmonary pressure is high, plugging in the IVC into the branch pulmonary arteries is going to cause this Fontan circulation to fail, because there is insufficient gradient for passive flow, and therefore the patient will not survive the Fontan completion. Beyond just measuring pressures, we can use various ways to estimate or to calculate the pulmonary vascular resistance and index it to the patient's body surface area by making certain assumptions, or if we have the ability to measure oxygen consumption directly, which we do not have at the moment in NUH, we then use the Lafarge formula to assume oxygen consumption for us to be able to assess the pulmonary vascular resistance. Beyond just doing diagnostic assessment, if I need to do intervention, for example, for the same patient, usually the cyanotic patients would have lots of collaterals, and we can use cardiac catheterization to plug up some of these collaterals prior to sending for surgery to minimize or to mitigate the risk of bleeding and to ease the surgeon's task at hemostasis. So I can put in vascular plugs to plug up all these collaterals there. So in conclusion, pre-op cardiac assessment basically is imaging. There are other things that we need. Of course, we need history, physical exam, ECG, and chest X-ray. But from the purpose of specific cardiac pre-operative assessment, it is mainly in this imaging in the setting of congenital heart disease. But what imaging study? Echocardiogram is still the first line of diagnostic imaging test, without a question. But when do we perform other imaging modalities? Meaning, when echo is not enough. But when is echo not enough? When the acoustic window is poor, with limited echo views, the extracardiac abnormalities we need to assess, if we need to measure right ventricular volume, if we need direct hemodynamic assessment, or if we need intervention to be performed at the same time, that's when we move on to other form of modality of assessment.